Good morning, everybody, and welcome, to our fully online virtual edition, the 2020 COVID edition of the Vanier Social Science Festival. Hopefully some of you have already taken in some of our talks. We're in our fourth and final day. We have two more talks today. Before I introduce our speaker for this morning's presentation, a quick rundown, everybody, for the attendees about how this is going to work. Basically, I will introduce our speaker and turn things over to him in a few seconds, and the speaker will make his presentation. At the end of the presentation, there'll be a Q&A period. I encourage you, while you're listening to the talk, to actually jot down or think of questions that might pop up or in your mind based on what you're hearing, and be ready to ask a few questions at the end of the presentation. Unfortunately, you know, the way this works is you don't have access to your mics nor your cameras, so we're going to use the Q&A function, or the question and answer function on your Zoom screens, to be able to ask questions. So you'll have to type out your questions. And I will then read them to Professor Weinstock, our presenter this morning, and he will then answer your questions, and then we'll move this way from one question to the next. All right, so without further ado, I'd like to present to you guys our speaker for this morning. Professor Weinstock teaches at McGill in the Faculty of Law and the Department of Philosophy. He holds the Catherine A. Pearson Chair in Civil Society and Public Policy, right? And until this year, he was actually the director of the Institute for Health and Social Policy at McGill. He's got lots of published work, an accomplished academic, and he really looks at or focuses on, you know, ethical issues, normative issues, dealing with public policy as it relates to healthcare and education. So I am thrilled and excited. I was very happy that Professor Weinstock actually accepted our invitation to speak to us. It's a great privilege to be able to introduce him to all of you. So I'll turn over things to him at this juncture. It's yours. Go ahead, Professor Weinstock.
Thank you very much. I'd like to begin by thanking the organizers of this event for giving me the chance to meeting with you virtually. It'd be nicer to be in an actual seminar room or classroom talking to you in the real world, but this will have to do for this year. I'm going to share my screen. This is the exciting moment where we hope the technology works and that the people behind the technology actually know how to make it work. So let's see what happens. All right, so the theme for this year's Vanier Social Science Festival is community, and I'm going to spend my time with you linking the idea of community to some of the issues that we've been facing in the last almost 8 months now as we try to get a handle on the COVID-19 pandemic. So I've spent a lot of my career thinking about community as identity. What is a community? A community is a group of people who share some kind of salient identity marker. That could be religion, it could be ethnocultural, it could be language, excuse me. And you know, what are the strengths and pitfalls of a conception of community that is conceived of as identity? I'd like to think about community today in a slightly different way. I'd like to think of community as solidarity, right? A community is a group of people not necessarily linked together by any of those salient markers that I mentioned a moment ago, but rather people who are committed to each other's well-being. So what do I mean by solidarity? I define solidarity as, so this is a little bit technical, equalizing vulnerability, right? So equalizing vulnerability. What is vulnerability? Well, vulnerability is the likelihood that you, if some kind of you know, bad event is affecting the community, you're more likely than others to suffer negative consequences of that, right? So that makes you vulnerable, right? a community, according to the conception of community as solidarity, a community is a group of people who try as best they can to equalize the degree to which each one of them is vulnerable to the inevitable natural or social bads that from time to time occur in any community. So it looks something like this, right? Now, obviously that's an image drawn from the internet. Everybody kind of looks the same under that picture. I wish I'd had a picture where people looked a little bit more diverse, but the basic idea is this, right? There's the umbrella and it's protecting all of us equally. Nobody is sort of outside the protective cover of the umbrella. So if it starts raining, well, we may get a little bit of a splash. The umbrella may have a little bit of a hole in it somewhere. It may blow from side to side from time to time, but basically we're all covered equally. Now, contrast that with this. So I don't know who that guy is. I just pulled this image off the internet. The umbrella is covering part of the community, but not another. It's leaving some people completely in the rain. So again, just an image taken at random from the internet. I don't know who those two people are. Actually, I do, but let's put that aside for now. And it's also not something like this. So sometimes we have umbrellas that are so bad that they actually kind of, not only do they not cover some people in the community, but they actually harm them, right? They actually are designed in such a way that they're counterproductive. They actually add to the harm that whatever it is that they're supposed to protect us against already sort of subjects us to. So that's actually the Queen of England having an umbrella malfunction, but it's the best that I could find to illustrate that other point. So what we want is, when we try to establish community as solidarity, we want to look more like the first picture and less like the second and third. We want to have umbrellas that cover all of us equally, and we want to have umbrellas that don't themselves turn into harms for some members of the population. Now, it's hard to know how well we're doing with respect to our community as solidarity when things are going pretty well, right? When the sun is shining, well, we don't really know how well our umbrella is doing because we don't have to, bring it out. There's a group of people who are obviously enjoying a warm sunny day by the beach. They all look happy, they're linking hands. But we don't know what'll happen in this picture if the sun is replaced by rain. Will they all be equally happy? Will they all be equally protected? Now, I don't want to exaggerate the analogies, but think about the situation that we were in Quebec in January and February of this year, up until January and February of this year. Unemployment rates were at record lows. The economy was going well. There were certainly problems in our society that needed addressing, but we were kind of a little bit more like this than we were, a community sort of huddling against the elements. So the first point that I want to make in this presentation today is that crises reveal community. Crises tell us something about whether we have managed to establish a community that is characterized by high levels of solidarity, or whether we haven't. So crises reveal to us whether we look more like that nice picture at the top left of everybody being covered by the umbrella, the middle picture, one person being protected by the umbrella, another not, or the third picture where the umbrella is actually turning against us. So, I'm sure you've all figured out the analogy or the metaphor that I'm working with here. The umbrella is sort of our social policies, right? It's the policies that we, through our democratically elected representatives, provide ourselves with in order to protect ourselves against some of the foreseeable harms that will inevitably affect us at some point in the life of our community. So do our policies represent an umbrella that protects us all? Does it really just protect the privileged, like in the second picture? Or are they so badly designed that they end up turning against some of the people that they're supposed to be protecting, like in that third picture? So I want to turn now to thinking about COVID-19. So COVID-19, which obviously is one of the biggest events that any of us is ever going to face in their lifetimes. We are now almost 8 months into the COVID-19 pandemic. It has upended pretty much all of our lives, our economies, the way in which we obviously educate and are educated. You know, about 9 or 10 months ago, I had probably participated in just a handful of Zoom meetings, and now it feels like my life is entirely made up of Zoom, like I live on Zoom. So it's upended everything about our lives, the way we socialize or don't socialize, the way in which we entertain ourselves. Everything has been changed by COVID. Now, at the beginning of the pandemic, in order to get us to take the public health measures that were being recommended to us seriously, there was a message that kept on coming through the public health authorities in this country, in this province, elsewhere, which is that COVID-19 doesn't discriminate, right? You could be young and healthy, old and enfeebled, or something in the middle. COVID-19 could come to get you as well. So just because you know, you're 20 and you think that you're invulnerable, well, you have reason to take the public health measures that the government has put forward seriously, because the message was COVID-19 doesn't discriminate. It attacks everybody equally. Well, 8 months in, we can see that that just isn't true. Yes, everybody is to some degree vulnerable to COVID-19, but it does discriminate. It does not affect people equally. So I'm just going to flash some numbers and some figures at you just to illustrate that. So 44.6%, 55.4%. If I had a classroom in front of me, I would ask people to sort of guess at what those proportions represent. Well, if you add them together, it gives you 100%. So obviously, this is a way of breaking the population, our population actually, as it happens, population of Quebec, into two groups, according to some dimension of their identities. And I would ask you to guess what that was. So maybe you could do it at home as you're sitting in front of your computers. What is that breakdown? What is that? Is it you know, bald people versus non-bald people? I'll give you a second to think about it. So it's men versus women. Okay, so of the total number of people who have been infected by COVID in Quebec, as of yesterday, these statistics are drawn from the Institut National de la Santé Publique du Québec website, which are updated every day. And so as of yesterday, the total number of people who were affected by COVID in Quebec, 55.4% of them were women, and only 44.6% of them have been men. So that's not an insubstantial gap. That's over 10% difference between the two. So that's one way in which it seems like COVID does discriminate, right? It seems to place women at greater risk of being infected. Now, this isn't a figure about health outcomes. This doesn't tell us about how badly or well people do once they have been infected by COVID-19, but it does tell you about a fairly significant gulf between men and women in their rates of infection. So here's another figure. This one's a little bit more complicated. So this is drawn from a study that was conducted by some researchers at the University of Montreal, who are actually looking at the ways in which COVID discriminates within Quebec. But as they're doing it, they're actually looking at some stats from other countries, and in particular from the United States. So what we've discovered, and again, these are very recent figures. These are figures that are still true as of about 2 or 3 weeks ago. And at this point, they're not going to budge very very much. If you take the 22% of counties in the United States that have the highest African-American proportion of African-American population, those 22% of counties account for 52% of the cases of COVID in the United States. So imagine you make a list of the counties in the United States, and you start at the top with a county that has the highest proportion of African Americans, and you just list them going down with decreasing proportion. Well, when you get to 22% of that list, when you get down to 22%, you've already covered, as it were, 52% of the cases of COVID. So it seems like in the United States, COVID discriminates not just according to men and women, it also discriminates according to racialized identities. Now, in Quebec, and this is a problem that we could talk about, we don't collect data as they do in the United States and in other places according to ethnocultural categories, black, white, whatever. What we do is we have breakdowns according to areas of the city of Montreal, for example. So that's a map that is drawn from the CBC. It's a few weeks old, June 8th. So it's a few, going back a couple of months. And as you could guess, the deeper the color of the red, the higher the level of infection. Now, if you look at the map, the area that has the deepest color of red, so the one that has the highest proportional number of cases of COVID on the island of Montreal relative to population, is Montreal North. Now, if you correlate residential district to socio-economic and ethnocultural categories, you realize that the pattern that I described for the United States in the last slide is probably true of us as well, because it seems like the places where there is the most ethnocultural diversity and the place where there are the most Montrealers of African descent are also the places that have the deepest colors of red on that map. If you look at places like Westmount and where I'm talking to you from, which is NDG, which are around here, I don't actually know if you can see my arrow, but these sorts of areas, we're kind of, we're definitely, we're seeing a lot of cases in June, but the shade of red or orange, as it happens, is a lot more sort of paler. Okay, so I could go on, and I think that we could see, according to a lot of patterns of advantage and disadvantage, that COVID discriminates, contrary to what people claimed at the beginning of the pandemic, that COVID doesn't discriminate, that it could come after you whether you are young, affluent, or older and poorer. Well, it seems that it does, right? It seems that whatever pattern of advantage and disadvantage existed before COVID, right? It seems like that pattern, those fault lines, to use the term that I provided for my title, have been exacerbated by COVID, right? And we can ask ourselves, well, why? So one answer might be biology, right? One of the reasons why COVID might affect certain categories of people more than others could just be biological bad luck. Certain categories of people are just more vulnerable to COVID because of something about their genetic makeup, and there's just nothing that we can do about it. Is that true? Is that the right way of looking at it? Does that bear out when we look at the evidence? Well, maybe a bit, right? Maybe a bit. So one of the things that 8 months into the pandemic we seem to know is that the older you are, right, the more likely you are to suffer very, very adverse consequences if you become infected. These are actually death rates that were taken early on in the pandemic at the end of March, but they haven't really changed very much. If you were to do a bar graph of death rates today, it would follow roughly the same pattern. So, you know, if you're in the 15 to 44 age group, your likelihood of succumbing to COVID is fairly low, and it's obviously a much more of a health risk if you are in the 75 and above ranges. So age does seem to have something to do with it. But at the end of the day, what I want to convince you of is that it doesn't really account for very much in the explanation of why certain groups are affected more than others by COVID, both in terms of how likely they are to get infected and in terms of how likely they are to suffer adverse consequences if they get affected. As the host mentioned at the beginning of the talk, I used to run, I finished my term as director 2 months ago. I spent 7 years as the director of something called the Institute for Health and Social Policy at McGill University. And what the Institute for Health and Social Policy does is it engages in research that tries to establish what the social determinants of health and disease are. What are the aspects of people's social identities, of people's social situations that might make them more or less vulnerable to different kinds of disease? It turns out that social determinants, how rich you are, how much money you have, where you live, what kind of housing you live in, what form of transportation you take to get to and from your work, all of these things have a very powerful predictive impact on how vulnerable you are both to communicable diseases, infectious diseases like COVID, but also to non-infectious diseases like type 2 diabetes, for example, or high blood pressure, or things of that nature. So what I want to convince you of is that biology, genetic luck and bad luck only account for a very, very, very tiny amount of the explanation of how come COVID discriminates as powerfully as it does. Okay, so here's a picture, and I want you to look at it because we're going to spend quite a bit of time sort of thinking about this picture. So this is a picture that was taken in a CHSLD, a long-term care facility run by the province to care for elderly Quebecers. And as you see, there are two sort of healthcare workers there, préposés aux bénéficiaires, as we call them, people who really work the front lines, making sure that people are fed, making sure that their bodily needs are taken care of. And there they are with one of the residents of one of these long-term care facilities. Now, as you know, long-term care facilities, both public and private, in Quebec, but elsewhere in the world as well, were devastated by COVID. We're devastated by COVID. The rates of death in the early phase of the pandemic were just catastrophic. Now, you might look at this and say, well, biology, right? You have old people who are vulnerable, who are probably affected by numerous comorbidities. That means that there's more than one thing wrong with them, who are in these places. Of course, they're going to be more vulnerable to the more damaging effects of COVID than the rest of us. But I want you to consider the different ways in which decisions that we have made as a society have increased their vulnerability considerably. So I'm going to run through a number of factors of social determinants that have made that the case. Okay, one of the first decisions we made early on in the pandemic was to say, okay, if a lot of people get sick in the community and a lot of people need hospitalization, we need to free up a lot of space in the hospitals. We need to have a few thousand beds in the hospitals that are available for what people refer to as surge capacity, in case we really need to take in a lot of people for hospital care, intensive care in the hospital. So what we did was we liberated a lot of hospital beds by sending older people who were in hospital for a long period of time into long-term care facilities, CHSLDs, like the one that this picture is taken in, so that the hospital beds could be increased. Okay, well, you might say, that makes sense. You know, you want the hospital beds where acute care can be delivered to be free, and these people can be cared for in long-term care facilities. Well, another thing that we did, and this affects, you know, if you look at those two people who are caring for us, the long-term care facilities and also private care facilities have been subjected in the last years, decades, well before COVID, to something that we might refer to as rationalization of human resources. So a lot of people who want to make these places work as efficiently as possible looked at them and said, you know, there are a lot of periods of the day where the people who work in the CHSLDs aren't really doing anything. It could be that they're just needed 2 or 3 hours a day in any given CHSLD. Let's rationalize the use of our human resources by having them work in several places in the same day. If they're needed for 2 hours here and 2 hours there and 2 hours in a third place, let's basically move them around so that in an 8-hour day, they're actually providing 8 hours of service, more bang for the buck. You know, that means that you have a lot of people working not just in one place, but in several places, delivering services to different clienteles in different buildings, in different CHSLDs. Now, a lot of the people who work at the front line in these places, the people who are cleaning, you know, making sure that people are bathed, making sure that they get their food, you know, taking care of, you know, very intimate bodily needs that these people have, are part of what we refer to sometimes as the precariat, right? Comes from the word precarious. If you look at the picture, isn't very clear, unfortunately, but these are both racialized women. A lot of the people who work as frontline service delivery people in the CHSLDs are people who do not have good unionized jobs with contracts and all kinds of protections. There are people who sign up to agencies who ship them back and forth between CHSLDs according to need. Now, these people often have complicated immigration statuses. As we know from a lot of the stories that broke during the beginning of the pandemic, a lot of them are asylum seekers, people who are waiting to receive status in Canada. They're people, therefore, who don't really, you know, can't really complain about the work conditions that they're in because they're in a position of great immigration and socioeconomic vulnerability. They're precarious in their employment, and they don't necessarily have the kind of union protections that other workers have, both in the healthcare sector and outside of it. Now, that picture shows you two people who have, it looks like, adequate personal protective equipment. They have the robes, they have the mask, they have actually the face protector, but a lot of people who worked in these circumstances did not. They had to shuttle back and forth between facilities, and even when they were within facilities, back and forth between quote unquote hot and cold zones of the facilities without adequate personal protective equipment, and in a status that makes them perhaps a little bit more concerned or reluctant to complain about the fact that they have not been given adequate protection. So insufficient PPE, insufficient personal protective equipment was one of the things that was one of the you know, big themes of the discussion of the spread of the pandemic in the early days. So you put all of those factors together, right? You put a number of decisions which, if you look at them independently, might look like good decisions. You know, let's liberate some space in the hospitals, move all of the people who are not needing acute care back into the CHSLDs, back into the long-term care facilities, use the personnel that is there efficiently, which might mean shuttling them back and forth, even in the space of the same day, back and forth between different facilities. They're precarious, so they're not necessarily the kind of people who are going to speak up to complain about the fact that they're not given adequate personal protective equipment. Put all those things together and you get the catastrophes that occurred and that are still unfortunately occurring, making already vulnerable people the elderly, even more vulnerable than they would otherwise have been. So this is CHSLD in Laval, where at a certain point there were 100 deaths just in that facility. The tagline on that slide is early on in the pandemic. They talk about 968 people having died in Quebec CHSLDs. Far more than that today, unfortunately. So the point that I want to make actually are two. The first one is we said that biology might account for some of the ways in which COVID discriminates. Older people more at risk, and that's true. But look at how some of the decisions that we have made as a society, right, make those people even more vulnerable. All those decisions that I've just talked about how to govern and administer long-term care facilities, about how to govern the hospitals, have had an impact on increasing the rate of vulnerability of the category of the population that is older people. The umbrella wasn't working particularly well for those people. I'll add something else, a second point. It will not have escaped people's attention that the two people who I showed on the previous slides caring for that older resident were racialized women. Remember what I said at the very beginning, 55% roughly of women and 45% roughly of men infected by the virus. Again, that's not an accident. That's not a question of biology. That is because a lot of the people, a disproportion of the people who occupy those precarious and dangerous positions in the healthcare sector are racialized women. Now, so that explains, not biology, but social policy explains why you have that split, 55-45. It also explains, remember the map of Montreal that I showed earlier, why certain areas of Montreal were affected more than others. These are places where rents are relatively cheaper. People who work in the CHSLDs in the positions that I've described usually go back to those neighborhoods to live and unfortunately bring COVID back with them into neighborhoods that are more densely populated than are other neighborhoods in Montreal, and where social distancing is therefore more difficult in virtue of that greater density. So remember those first images. So what I've shown is that you know, the fact that the reign of COVID is falling disproportionately on different people, the elderly and racialized women, is not a fact about nature, it's a fact about decisions that we've taken. Remember that picture that I showed you about with the umbrella that actually, you know, closes in on somebody's head and harms them? Some of that has been occurring as well. So remember that at the beginning of the pandemic, and still to some effect today, we were told, stay at home, shelter in place, right? That's the best way of limiting our contacts, and therefore the best way of limiting spread. Well, if you live in that house, that's going to be pretty easy. You have a big house, you can distance yourself from other people who live in it, and the point that I want to make is that you have a lot of access to private outdoor space. You know, if you want to oxygenate yourself, go for a little stroll, just change your sort of perspective. You can go outdoors, lie on the grass, and still be obeying the imperative to shelter in place. If you live there, so that's actually a small apartment in Hong Kong. I cheated, that is a Montreal apartment. Much more difficult. You're living in cramped quarters, no access to private outdoor space. And so sheltering in place becomes something that is difficult, but also arguably harmful. If you are told that you can't leave your small apartment, imagine you have no access to the outdoors other than public outdoors. Imagine perhaps you're living with an abusive partner. Imagine all sorts of things that could make it the case that your very cramped and limited space is in and of itself harmful for you. Well, that starts looking a lot like the umbrella closing down around you and harming you. A policy that we're taking to protect us actually doing some harm to some of us and not others. I've run this story by talking about two groups that you might that have been disproportionately affected by the pandemic. You know, so racialized people, in particular racialized women, and the elderly, right? I've told the story very quickly. I could have given the same presentation, just changing the details in relevant ways in talking about all of these other different groups. And these are all groups that were disadvantaged before the pandemic began, and that the pandemic just intensified the disadvantage of. So I'll just run through them, and in maybe question period, we can talk about the different ways in which these groups were left outside the umbrella of protections, and sometimes even harmed by some of the protections that we adopted in order to protect the whole population from the pandemic. Okay, so I hope everybody's not too depressed right now. What I've basically shown is that it looks like we haven't been too good at establishing a community marked by solidarity, because it looks like you know, we've left a lot of people outside the umbrella. We've used umbrellas that have actually harmed people to significant degrees. So I don't want to end this presentation with only bad news. Is there any good news that comes out of this? Well, I want to say that there is. So remember what I talked, oh, and I have a typo there, vulnerability, sorry, vulnerability it should be. I talked about the fact that, and this has been a very brief exploration of the idea of social determinants of vulnerability, right? The idea that certain people are rendered vulnerable, not by their biology, or in the case of elderly people, not just by their biology, but by social determinants, by aspects of our social organization that increase, or that in some cases create their vulnerability, in this case to COVID-19. You know, not too good in terms of how we're doing as a community, but the thing about social determinants is that they are modifiable by policy, right? All of those things are not just hardwired facts about our society, they are policy decisions. Some of them gave rise to foreseeable negative consequences for these populations. Others perhaps didn't. Others were, think about moving older people back into the CHSLDs. Maybe, you know, if we think about it charitably, we think, well, you know, maybe there was no way of foreseeing just how terrible a decision that was going to be, but we learned from it. So if something is modifiable by policy, that means that we can do better. If we are animated by the idea of community as solidarity, we can, when the dust settles on this terrible episode in our history, look back and say, what are the things that we did that created vulnerability for people, and how can we change them? And that's the good news. Policy can be improved in order to make us look less like one of those pictures of the people being not covered by the umbrella or being harmed by the umbrella, and more like this. So that's it. Thank you very much for your attention, and I hope that there are questions.
Surely a very highly interesting, informative analysis about the situation. I especially liked the metaphor with the umbrellas of unrecognizable people. I have a question up on the board, so I encourage the rest of you to start thinking about your questions and writing them out. So we'll start with the first one and go from there, all right? So first question, Professor Weinstock, has the Quebec government taken measures to address the CHSLD problems?
So I think that they have, but so far I think that they're insufficient. Now, I want to be clear, these are huge problems. How to deal with, you know, we have an aging population. We have a population that every year, the proportion of the population that is older increases. And so there are more and more people who need kind of geriatric care designed for the elderly. So this is a huge societal problem. One of the things that the government has promised is that when we get out of this situation, we're going to rethink the whole way in which we care for the elderly. I mean, anybody who's ever visited a relative in the CHSLDs or in private care facilities will know that just in virtue of the density, just in virtue of the fact that you have all these vulnerable people living very close to one another, sharing often bathrooms, eating meals in communal space, there's a disaster waiting to happen if if an infectious disease outbreak breaks out. Now, COVID-19 is the most dramatic of the outbreaks that we've had by several orders of magnitude in our lifetimes, but there have been others in CHSLDs. There is a virus that sometimes spreads called C. difficile, which is an intestinal bacteria, I think, that has spread through the CHSLDs like wildfire, and in the past, it has given rise to a significant number of deaths, unfortunately. So we know these problems, and so the government has promised that we would rethink the whole way in which we house elderly people. But for now, I think a lot of the solutions have been slightly Band-Aid, but not, you know, so what are some of the things that, that create the great vulnerability of these places? I didn't mention all of them. Low rates of pay, right? If you're working at a crucial function, taking care of older people, feeding them, making sure that their bodily needs are met, but you're not being paid well and you don't have the kinds of jobs protections that people have, it's very easy to walk away from those jobs when things go sour, as they did. And a lot of people did just walk away, partly because they got sick themselves, but also because, well, you know, they're not particularly good jobs. And so we ended up with a huge shortage. You might remember in some of those early weeks, the premier, in a slightly panic-stricken voice, reaching out for volunteers, reaching out for people to come back and work in the CHSLDs. You know, you had the unbelievable sight of somebody like Joanne Lau, who is a Quebec physician who until recently was the director, the world director of Médecins Sans Frontières, volunteering to work in a CHSLD because the shortages were so terrible. So a few of the things that have happened is that rates of pay have gone up. I think, although I haven't checked in the last on the reporting in the last few days, that the provision of PPE, of personal protective equipment, has gotten better. But every day we get anecdotal stories coming out of the media of nurses saying, you know what, the organization of these places is still such that we have to run back and forth between hot zones where there are people who are infected with COVID, and cold zones where we hope there aren't people being infected with COVID, you know, whose lives have been made even more difficult by COVID than they were before, are the homeless. I mean, just think about being a homeless person in the context of a pandemic, right? You're being told to shelter in place. Well, you don't have any shelter, so how's that working? Much harder to maintain social distancing if you think about the sort of tent communities that have exploded in Montreal and elsewhere. Well, you know, much harder to make sure that you're respecting all of those public health, wash your hands, you know, et cetera. When you don't have proper access to facilities, to plumbing. Think about how reliant we are on the internet. I mean, these are all things that are really sort of meat and potatoes stuff, right? Sorry for the vegetarians there for the reference to meat, but they're really very basic. A lot of the information that we get from the government is information that is transmitted through the internet, well, or, you know, cell phones. If you don't have the, you know, access to the internet, if you don't have a cell phone because you're living rough, well, you know, you're kind of left outside of the umbrella a priori, right? Without even anything, you know, just from the outset. So, so Mayor Plante has said that there would be nobody in the winter this year living rough, having to deal with pandemic situations, living rough. Now, that invites the next question, which is, well, how are homeless shelters going to be set up in pandemic circumstances when we know that homeless shelters are not places where social distancing is particularly easy to maintain? Well, that's another question, but at least there is awareness of the problem. There's a deep, but again, just like the older people, there are Band-Aid solutions, and then there are deeper solutions. I think that one of the things that the COVID crisis reveals is that housing is a social right. It is as important to your well-being as access to doctors and hospitals is. We treat it like a commodity, right? We treat it like something where we just let market forces take over and determine whether you live in a house where you can easily shelter in place because you've got tons of room and you've got a backyard or a front yard or whatever. And, you know, whether you live in a very, very cramped apartment, intergenerational, where because you don't have much money, you have to have mom and dad living with you and maybe your kids as well, you know, getting that virus to cross generations. Well, once we have told people that they have to shelter in place, we have acknowledged that place, that home, is a resource that is as important as transportation, as important as hospital medical care. We have acknowledged that it is a social right and that it can't just be up to the market to determine whether we will be adequately housed, because in situations like COVID, where we live has a big impact on whether we frankly get sick or not. And so, you know, my hope is that when the dust settles, we will address that. And, you know, that social housing will become something that we do more than something that we sort of talk about, and that we will recalibrate the way that we think about housing as, you know, not so much a commodity that like a car or, you know, whatever, shiny, whatever piece of technology that you like, but more like a right.
Perfect, thank you. So somebody's asking, or the next person's asking, how come LGBTQ people are more likely to be affected by COVID-19?
Okay, so there are a whole number of ways in which the causality can run here. I'll just give a couple of examples. Some people in the LGBTQ2+ community are people who are in the course of certain kind of medical treatments that are required in the course of transitioning. As you know, one of the unintended consequences of the overloading of the hospitals due to COVID, we have a certain capacity for hospitals and for medical care. That capacity has been more or less mobilized for surge situations with respect to COVID, is a lot of medical procedures of all kinds have been delayed, deferred into an indefinite future. Now that's true of people who need knee replacement surgery, or you know, perhaps other kinds of surgeries that might be less sort of life and death. But it's also true of some people in the LGBTQ2+ community who are undergoing certain kinds of treatment in the course of their transition. So that's answer number one. Answer number two is, you know, one of the things that I've been very concerned about as, you know, we use kind of shelter in place as one of our main policy responses to COVID, stay in your home, basically, right? Is that, well, a lot of people are in home situations that are difficult and bad for their health, not just because they are small, right? Like that slide where I had with a lot of people intergenerational sort of crammed together, but also because they're dangerous. A lot of women living with abusive partners being told, look, for the foreseeable future, you're just going to have to stay there, even if you are in an abusive relationship. And I think that there are a lot of, you know, there are a lot of reports that suggest that, you know, a lot of trans youths in particular have sort of been forced into situations where they are forced to shelter in place with transphobic families, for example, which is something that can have a huge impact sometimes on their physical health, but very often also on mental health. I haven't talked at all about that. It's another feature of the crisis, which I think at some point we as a society are going to have to address for everybody, right? Which is the mental health costs of the ways in which our lives have changed, and ways in which our lives have changed in a much more stressful and mental health affecting way in some situations for trans kids more than for others. So those are two ways in which I think that there are causal vectors that have made the situation very difficult, both from a physical and from a mental health point of view for people from the LGBTQ2+ community.
Okay, we actually have 5 questions on the board.
Okay, I'll try
We
to be
have,
briefer in my answers.
yeah, I would like to try and get through all of them if we
Sure,
can.
I'll be
Right.
brief. Yes, no.
Okay, so do you think the CERB benefit was a good thing overall?
Yes, I do. I think that one of the things that the CERB thing did is it gave people a buffer, which made it the case that they didn't have to accept just the first job that came along that might be dangerous, to them. There's an idea out there which I don't have time to talk about because we're under the gun for time, which is the idea of a universal basic income. The idea that citizens should receive a basic income, either annual or monthly, that gives them that kind of a buffer. And I think that what the CERB thing has done was just show that that has been a good idea. Now, the CERB, imagine being a person who doesn't have access to the internet and trying to fill out those CERB forms. We have to be attentive to the ways in which even an egalitarian policy like CERB sometimes reveals inequalities, for example, amongst people who just aren't able to get to the technology that they need in order to fill out the forms. But in general, yes, I think it was a good idea.
Okay, so how can we as a community come back or undo the damages that have been done by some of our policies?
Okay, huge question. I think I'm just going to answer with, first, we have to acknowledge them. We have to acknowledge them. In other words, all of the things that I've been describing, and I could have spent hours describing, other ways in which marginalized and disadvantaged communities have been hard done by. We have to just document, as I did very briefly, the ways in which we did more poorly. And quite honestly, we have to, when this is over, not forget. There's going to be a great temptation when this is over just to get back to life as usual, especially if we're fairly advantaged people, middle class, upper middle class, white, whatever, just to go back to the way things were before. It's all of our responsibility, to put a lot of pressure on our elected officials to say, hey, wait a minute, right? We just went through this and we learned some lessons. Please, let's not forget those lessons. So pressure on our elected officials, unrelenting pressure.
Okay. In your opinion, do you think that the areas that are most affected in Montreal are also related to the poverty of those areas?
Sure.
Do you think that social class has an influence in the discrimination of COVID-19?
Yeah, absolutely. So I used, in one of those slides, I used the fancy social science term that is used now to talk about class, which is socioeconomic status. But yeah, absolutely. So there's a term which you guys have probably learned about in some of your social science classes already. If not, you're going to learn about it soon, called intersectionality. The idea that all these categories of disadvantage aren't separate completely, right? They're discrete. So racialized people are often people who are disproportionately represented in lower SES, in lower socioeconomic class. So the answer is absolutely. If you have less money, then you have less money to pay rent in a place that will give you the sort of commodious circumstances that will allow you to shelter in place. If you have less money, I mean, the internet, broadband, has been revealed by COVID to be a social determinant of health. Whether you can access healthcare now depends on your being able to access telemedicine. Whether you're able to access broadband will determine whether you can regularly get to all the messaging that's coming out from public health. Broadband ain't free, right? And cell phones, right? Think about that app that we're being told that we should download onto our cell phones to see whether we're at risk or not. As last time I looked, cell phones and cell phone subscriptions weren't free either. And they're pretty expensive, and in Quebec, maybe more expensive than in a lot of places. So if you have to choose between putting food on the table and upgrading your internet connection, you're going to choose food, and you're going to put yourself at a disadvantage relative to a lot of things that. So I could go on and on and on and on, but yes, absolutely. SES, what we used to call class, is absolutely a vector through which advantage and disadvantage in the COVID period are transmitted.
Okay, so you said that COVID-19 is discriminating against women because more women got infected. By definition, the meaning of discrimination is the unjust or prejudicial treatment of different categories of people or things, especially on the grounds of race, age, or sex. With that said, how can we argue, or can it be argued that a virus is discriminating?
So I was being kind of a little bit provocative by saying that COVID discriminates. What discriminates is not COVID. I mean, the whole, the point of the lecture is to say that what discriminates is our policies, right? And COVID acts like a grand revealer, right, of the degree to which our policies are discriminatory. It's 10:58. So why is it that there is a sort of disproportion of racialized women in those extremely dangerous, poorly paid, and poorly protected jobs that I described, amongst other things, in the CHSLDs and in the private care facilities? Why are so many racialized women doing those jobs which we, and maybe this is something that will change, consider to be at the lower echelons of the sort of hierarchy of positions? Well, that's a question which goes directly to yours, which is that we have somehow put in place a set of laws, of incentives, of constraints in access to education and to labor that make it the case that when all these things are brought together, we end up with a disproportion of racialized women in these positions. No one of these policy tools can be seen as discriminatory, but their total effect, right, does seem to be. It's systemic, right, to use a term which is being debated like a hot potato in Quebec these days.
Ah, yes, systemic and the semantics. All right, so we have two more questions. All right, one of them is asking which of the umbrellas, the three different umbrellas, I guess, that you showed us, or which of the umbrellas or social policies do you think that are the most important in three discrete geographical locations: Montreal, Quebec, and Canada?
Wow. So Montreal, Quebec as a province, you mean? Okay, so not the city of Quebec. So I would say that, again, each power has to stay within the range of the powers that actually inheres in it in a federal structure. So, it turns out that the federal government doesn't actually have, outside of the criminal law and foreign policy, right, a lot of the other powers are provincial. So to be honest, I think that the federal government has done a lot of what it should have done by basically spending a lot of money. We're going to have to deal with some of the fallout of having spent a lot of money, to support people through programs like CERB, to support people through subsidies to small businesses that are being threatened with extinction by the economic consequences of COVID. So, the federal government has the spending power. It can decide on, essentially how much money there is in the economy. And I think that it has done what it should do, which is spend money. I think with respect to the city, this goes back to what I was talking about earlier. The city doesn't really have many powers, but what it can make sure is that, people are adequately, at least on an emergency basis, adequately housed at very minimum, not forced to live on the street. It turns out that the provincial government is the level of government that has probably the most levers at its disposal. So if there's anything that you take away from this lecture, it is this. It is imperative that the provincial government, when we get out of this, not see COVID as just a health care crisis, but as a social crisis that affects all aspects of its policy agenda, from education to, well, obviously, healthcare, but public health more broadly, right? Where public health is understood not just as what happens at the doctor and in the hospital, but more generally at the way in which we have preventive policies in place that allow people to protect themselves from getting sick in the first place.
Great, thank you very much. So we're going to wrap things up here. Well, first of all, thank you very much, Professor Weinstock. It was highly stimulating.
Thank you for all your questions.
Yeah, highly stimulating, highly informative, great analysis. So folks, one more presentation later today and the festival wraps up. So I hope to see many of you there, and everybody have a good day. And thank you very much once again, Professor Weinstock.
Thank you, everybody.
All right.